My name is Abe Jacob. I am Chief Medical Officer here at the University of Minnesota Masonic Children's Hospital, a hospitalist and a general pediatrician. Welcome to the applicants and back there. I hope you enjoy your visit, and to everyone else who's here to be a part of this grand rounds. Well, today is a historic day. We have a Game 7 tonight, which is awesome. But it's also historic because Rich Brilli is visiting, which is also awesome. Let me tell you a little bit about Rich before he gives his grand rounds. So Rich is Chief Medical Officer at Nationwide Children's Hospital and Professor of Pediatrics in the Division of Critical Care Medicine, Department of Pediatrics at The Ohio State University College of Medicine since 2008. Prior to that, he was at Cincinnati Children's Hospital doing critical care. He was recently awarded the John F. Wolfe Endowed Chair in Pediatric Quality and Safety at Nationwide Children's. In 2015, he was awarded the prestigious Master of Critical Care Medicine by the Society of Critical Care Medicine. Dr. Brilli's primary area of interest include patient safety, healthcare quality, and intensive care outcomes and administration. He has authored more than 100 peer-reviewed manuscripts, book chapters, and editorial commentaries. His recent publications have focused on driving change using high reliability principles and pertain to a variety of topics such as safety, quality, prevention of healthcare-associated infections, implementation of rapid response teams, and outcomes associated with organizational safety culture. In addition, Dr. Brilli conceived of and helped develop the Nationwide Children's Hospital Fellowship in Clinical Quality and Safety, a 2-year postgraduate program with real-world hands-on training combined with obtaining a master's degree in business operations excellence from Ohio State University. He is a member of the National Steering Committee for the Solutions for Patient Safety National Harm Reduction Collaborative, which we're a part of, an effort 100 children's hospitals across the nation, actually now including Canada, focused on eliminating preventable harm. Dr. Brilli is also the co-chair of the Children's Hospital Association effort called IPSO, Improving Pediatric Sepsis Outcomes. This effort is now enrolling hospitals and will focus on reducing mortality and morbidity by establishing high reliability practices for the care of patients with sepsis and septic shock. Dr. Brilli is a reviewer of multiple peer-reviewed journals related on quality and safety and currently serves as the section editor on quality and safety for pediatric critical care medicine. He's also co-editor-in-chief of the newly launched journal dedicated solely to pediatrics entitled Pediatric Quality and Safety. Other than that, he's also a new grandfather of twins and a proud father and husband. And Rich, it's great to have you here. Thanks for spending the time.
Thanks, man. Thank you. Well, good morning, everybody. Thanks for the invite, Abe, and look forward to talking to you for the next couple of hours about quality. 3 hours, right? Is that how? 3 hours. Okay, good. I think this talk may be a little bit different than what you've heard in some of the solutions for patient safety stuff and the work that's going around that area as well. I'm going to focus on leadership, as you can see here. What a beautiful venue! It's spectacular. So thanks for the invite. So, is Bobby here? She'll be at the noon one. All right. Who knows who Bobby Carroll is? So, a few people. So, Bobby Carroll is the Senior Director of Patient Safety and Informatics at your hospital. Abe reports to her. She's at Children's.
Yeah, Deb Bodie is our...
Oh, well then no wonder nobody knew who she was. All right. Good information. I appreciate that. Hey, that's a good introduction. Start out with a mistake. Perfect. All right. I'm surprised then that the other place people didn't know her here.
But Deb Bodie is her equivalent.
All right. Where's Deb Bodie? Is she here? All right. Sorry, Deb. So who knows Deb Bodie? All right. Good. We're finally back on track. I'll get it right eventually. So I have to tell you, I have no disclosures. And I don't have anything important anyway, so we'll move on to the next. And thank you for the kind introduction, Abe. Just a quick about Nationwide Children's. We're a 600-bed hospital, 1 million outpatient visits, 30,000 surgeries, 85,000 ED visits. Keeps me busy, keeps everybody busy. It's a great place to work and a fun place to work with a good culture around focusing on what's best for the patient. And that's a little bit of a theme you'll hear this morning. So on the way here yesterday, it was beautiful, and I was asking a lot of questions of the driver who took me here, and we're talking about the beauty of the Minnesota backcountry. And I talked about going up to the backcountry and seeing the trees and the lakes and all those sorts of things. So he told me that if I go up there, that the state bird of Minnesota is the mosquito. And I said, well, what do you do if you're going to go up there? And he said, well, the next thing is state deodorant is off or deep. So I now know how I can get up to the North Country and see a little bit more of the beauty of Minnesota. Searching your website. This is your internet, not your intranet. That's really good to have data on your internet for people like me from Columbus and other places around the country. You have some pretty good bloodstream infection rates. Maybe a little bit of opportunity to improve around pressure ulcers, but again, it's out there for people to see, people to learn from, for you to learn internally. So transparency is a good thing. But how many of you have been to this site or looked at data on this site in the past month? Raise your hand if you have. So a few. There's two reasons to have stuff on the internet. It's so that you internally can see how you're doing, and it's so that people from outside can look and compare and contrast. And if you're doing something better than I'm doing it nationwide, I can call up Abe and say, how are you doing that? How can I achieve the same results you are? So you got a lot of data on your internet. Do you have information on your intranet behind the firewall?
Yeah.
More data?
Yeah.
So I would strongly suggest you look at that stuff periodically. Do you have it by unit, or is it for the whole hospital?
It is now by unit.
All right, so maybe after I'm done talking today or tomorrow, take a look at what's on your internet and intranet. There's a lot of good information there. You guys have some great results. You should be proud of it. But at the same time, you're the ones who need to know it. I don't need to know it. You need to know it because you're the ones driving the change here in your institution. So we're going to talk about how leaders drive change. We're going to talk about some results, and then maybe what the future is. And like I say, this is not a solutions for patient safety talk. This is not about SBAR. This is not about QVV. This is not about some of the error prevention tools, although those are very, very important, and many of you have probably been through the training to use those tools as a way to reduce human error and improve outcomes. So Cotter has a whole industry, and I mean a whole industry around how leaders can drive change. If you haven't read his book, it's really worth reading to give you a sense of urgency around how leaders can drive change. So 15, 18 years ago, if you were doing QI, you're a bit of an oddball. That was me. Now, if you're not doing QI, you're an oddball. It is now mainstream. It's the kind of thing that all of us should be doing. And all hospitals, I think, are doing it in varying degrees. But the thing that excites me in terms of thinking about improvement is that it's no longer outcomes that we sweep under the carpet. When I was a younger physician, infections, ventilator-associated pneumonia infections, bloodstream infections, they often ended up on my desk, and they didn't go anywhere. And sometimes we didn't even talk about them at the organizational level. Talking about that. And transparency within an organization is how we drive change. If you don't recognize the problem, you're not going to be able to solve the problem. So this is all about you and me and our systems changing how we do business. You and me and our system changing how we do business. People don't like to change their habits. Everybody in this room likes the way you do whatever it is you do. And when Abe comes to you, or Brian Joy comes to you and says, we need to do something different, the first response is, why? And then I don't really want to change because I like how I'm doing it and I think I get good results. Everybody in this room is a leader. And we're going to talk a little bit about how you as a leader can help influence and drive change in your microsystem. Leaders make change just how we do business. If we're not changing, we're not progressing, and we're not going to get better outcomes. So we need to be thinking about how we achieve that. You have to know where you're going, whether it be zero harm or improved outcomes on your infectious disease unit or in the cardiac ICU aspect of the ICU from Brian's standpoint, where you're going. And you have to have a plan. You have to have a plan on how you do that. So I said everybody in this room is a leader. Abe is a C-suite member. There's chiefs in here. There are service line leaders. There are nursing leaders. There are frontline staff, hopefully in this room. All of you are leaders. And people watch how you show up. So if you show up and Abe says, we're going to do this change, and as soon as Abe leaves, you roll your eyes and that's a stupid idea. We're not going to really do that. Even if you're, a middle manager, nothing's going to happen. you need to show up and at least have bought into, hopefully Abe can convince you that it's the right thing to do. But if you're rolling your eyes and the medical students in the back there are seeing you rolling your eyes, they know you're really not into whatever we're trying to change. So you need to be demonstrative about how you approach change. So there are 4 characteristics we're going to go through here over the next couple of hours. As I said, you have to be able to articulate and sell a vision. You need to be able to inspire and manage teams. You need to have a method to achieve results, and then you need to celebrate success. Clear and understandable vision. And you need to be able to sell it. You need to be able to cheerlead it. So we're going to reduce bloodstream infections in our hospital, because it's a bad thing for kids, and sometimes kids die from that. Versus, children die in our organization as a result of bacteremia associated with bloodstream infection. We have to eradicate that. It's unacceptable to have that in our children's hospital. I could do the same sort of pitch, creating the burning platform overflow around if you don't get patients through your system, then they're waiting in the emergency room too long, and they're not getting into the system in a timely fashion, and there's harm associated with family satisfaction from that and other things. Almost anything we do here, you can pitch in a way that is compelling. But if you stand up there and Abe said I have to do it, so I'm going to, nobody's going to buy it. So you need to be able to, as a leader, whether it be Abe standing up in front of you and inspiring you that we need to focus on zero harm, or whether it be Brian in the cardiac ICU, these are the 2 people I know, so I'm picking on you guys, sorry about that. You need to be able to pitch and cheerlead why this is an important change. You need to be able to cut through all the red tape and just sort of have a simple message. We're going to eliminate harm. We're going to eliminate bloodstream infections. We're going to reduce flow, wait times in our emergency room from X to Y, and why is that important? Something simple that people can understand. And I think the biggest piece of this is creating a burning platform. So let me just tell you what I mean by that. So in 2008, when I came to Nationwide Children's, we had 514 serious harm events in 2008. Unacceptable. I told the board about that, and they had never heard that. They'd seen rate charts, medication errors per 1,000 doses administered, bloodstream infections per 1,000 line days, but they'd never seen 514. So when I said 514, there was silence. And then the next question was, what are you going to do about it? So when you make the number there, make sure you have a plan. Don't just throw the hand grenade in the water. Here's the problem, and here's how I propose we fix it. So there's 2 pieces to creating a burning platform. But how can you, if you're a clinician and you're in pediatric healthcare, be satisfied with 514 harm events in our organization? We're a big place, but every one of those is somebody's niece, nephew, brother, sister, child, grandchild. To make it clear, in 2009, we hadn't made much improvement, 446 children harmed, all the usual things that happen in your organization. 1 serious safety event every 11 days. That's either somebody we kill or somebody that we seriously harm with permanent injury. You have them too here. I don't know your numbers, but you have them here as well. It's 1.4 kids injured per day. Our serious safety event right now is a couple a year, 1 or 2 events per year, so that you can drive that down through a lot of different interventions. Making it personal. This is still under the category of creating a burning platform. This is Emily. So Emily was a child that came to our hospital probably about 15, 18 years ago, and she had hemolytic uremic syndrome, which is she had renal failure, and she also had some neurologic problems. She was on dialysis, and we gave her some IV fluids with potassium in it. Not a good thing if you have renal failure. She died in our hospital as a result of that medication overdose. She was 4 years old. And I used that story, which is a real story, name change, but real story, to inspire us around our Zero Hero program. We can't have any more Emilys in our hospital. In fact, in my view, every hospital has an Emily. You have one. I don't know if you've talked about it. You've either had one or you will have one. Every hospital in the country. And so we need to do the things around error prevention and harm reduction and all the various things we're going to talk about in order to make sure there's no Emilys in your hospital. If you haven't had one, congratulations, that's fantastic. But most places have had children die under our care due to medical error. Certainly the data nationally suggests that that happens. So we started a program called Zero Hero, zero meaning zero preventable harm, eliminate preventable harm. Hero, a heroic effort to get there. We branded it on purpose. Everybody in our organization, and Brian was there, is very familiar with the term and what it means. It means sometimes a little bit different to each person, but at the same time, it is a brand that says safety, reduce harm, expected behaviors that hopefully will get us to zero someday. We're not there yet. These are the things that we track, the Preventable Harm Index, which we talked about, and it's basically all of the various harm events. But the difference is it's not a rate. It's not a control chart. It's how many kids, that 500 kids, that 450 kids. People don't get inspired by 0.01 medication errors per 1,000 doses prescribed. I don't even know what that is. But in our place, that's 150 kids. 150 kids. Some minor medication errors, some serious medication errors. So it's about how many kids. And I don't know if you're talking about how many here, or if you even know how many kids were seriously harmed in your organization from 2015, but I think it's a good number to know, because it says we got work to do. Unless it's zero, in which case then we can be complacent. But I don't know any place in the country that's to zero yet. And we published this in the Journal of Pediatrics. So I think it's a concept that's key. And it's not heresy anymore. When we first started talking about this in 2008 and 2009, people would look at me and others and say, "You're crazy. It's an impossible dream. You're going after windmills that we'll never be able to achieve." But everybody's talking about zero. We're not talking about percent reduction. We're not talking about decrease. We're talking about eliminate. And I can't go to a family, I can't go to your wife and say, we're going to reduce harm by 50%. If that's one of your children, that's 100%. So we need to be talking about eliminate. We need to be talking about perfection. That's a word that stirs people up a little bit. Even Press Ganey, which is the group that does our satisfaction surveys, is in the game now with respect to zero. Is the Joint Commission next? I don't know. Probably they're going to be coming to us and asking about zero numbers. So the other thing about creating a burning platform is organizing as a leader. How do you get to where you want to go? So any meeting you go to where there's quality and safety stuff presented, they talk about the Institute of Medicine Transformational Domains of Care. I won't read all of those, safety being the one that's most high profile. I don't know about you, but I'm not inspired by these. In fact, as soon as I leave this slide, I can't even remember what they are, but they're out there. We've organized our thinking this way, which is around what does the patient and family need from us? Do not harm me. Heal me, cure me. They come to be healed and cured, right? But they don't want to be harmed. Treat the family and the child with respect. Navigate my care, which is the whole access throughput kind of thing. How do we get patients into, through, and out of our system in an efficient manner? And then keep us well. In other words, keep kids out of our hospital and take care of them from a population health perspective. Well, lo and behold, they all add up into the same domains. So we don't talk about the 8, we talk about the 5. And people in our organization know these various domains. In fact, all of our quality improvement work is organized under these domains. We publish that like this. The blue numbers are the number of projects we have in each domain. And this is just a sample of the projects that we have. And every time people come and present their quality improvement work to me, they'll organize their presentations, usually 6 to 10 presentations in each service line under these domains. And by the way, you can get maintenance of certification for your QI work. For those of you who are physicians in the room and you need maintenance of certification part 4, participating in or leading a quality improvement project, you can get maintenance of certification for that. Okay, so moving from selling and articulating a vision, eliminate, or under those 5 categories, to sort of how do you manage teams? Abe and I were talking about this last night at dinner. So, first of all, my view is every team needs to be multidisciplinary. There are no doctor teams. There are almost no doctor teams. There are almost no nursing teams. They all should be co-led. It could be nurse RT, it could be nurse physician, but there needs to be this QI is a team sport. It's not a doctor sport, not a nursing sport. So if you have a lot of siloed work, my 2 cents is it needs to be multidisciplinary. If you're already there, that's great. When you get teams together, you need to set some ground rules, especially around professional demeanor, professional conversation. And there's sometimes people who just don't know how to behave in a team. And as a leader, sometimes you have to remove them after a little bit of counseling. But most of the time, you can sort of help them understand how do you behave as a team member. But you need the naysayer. You need the guy or girl who always says, we can't do that, and here's why. And the reason why you need that is because sometimes they actually have good ideas. And if you're somebody who already knows the path, like me sometimes, and you don't listen, these are people who will sort of shake you a little bit and say, yeah, but what about this? What about that? So, you've heard keep your friends close and your enemies closer. This is not an enemy, but it's certainly somebody who will shake you up in terms of your thought process. You really want all of that. Expect excuses. Every one of these I have done. Every one of these I suspect everybody in this room has thought them and maybe even articulated them. I don't believe the data. I just did that last week. They presented some engagement data with our families, and the data just didn't look right to me. So I said this, even though, as I said it, I'm thinking, it's on my slides. How could I say that? We're too busy. My gosh. Quality improvement is the work. It's not extra work. It is the work. It's part of what we do. And if you think of it as separate, you're always going to have problems. But it is what we do. It is what I do almost full time. But every one of you, quality improvement and figuring out how do we drive change and get results is what we do. Because if we don't, you're going to continue to have the same outcomes unless you change. So that's a statement I often hear. And as soon as you measure compliance with whatever it is your staff say we already do, you'll find that it's 50% compliance, 25% compliance. And what you need to get change is 90% compliance with a particular process or policy, unless, of course, it's a bad policy, and then you should get rid of the policy. But this is a very ready-made excuse, and you have to deal with those two in the middle. This is the biggest one. There's no evidence for just about anything we do in pediatrics. Just about anything we do in pediatrics, there's extrapolated from the adult world. Maybe there's a few things. And those few things in pediatrics that are ironclad, well, we all do them, and it's not so much of a problem. But don't let anybody, and physicians in particular are bad about this. You got to where's the evidence? But I see people use that excuse all the time. My answer is, okay, let's take this on, let's give it a try, and let's make the evidence. Let's make the evidence. I don't see a clock back there, so I don't know what the time, is there a clock so I can see if I'm on time or not? Maybe I should stay by the podium then, just so I can get, all right, where's the clock? Oh, I see it. Okay. I got tons of time. I have an hour and a half to go. So I'm an ex-military guy, and I have a few pictures of leaders that I think are very effective. But leadership is getting others to do what you want them to do because they want to do it. You need to create the burning platform and then give it to the team or the group to work on and let them run with it. And you sort of tweak in, or maybe you're the leader. But all of a sudden, that work, whatever it is, whether it be bloodstream infection work or flow work or access time work, the team embraces it if you've set it up correctly. And all of a sudden, it's their work. It's not your work. And that's what you want, is you want them to embrace the activity, not for you to be swooping in all the time and say, fix this, fix this, fix this. I like Harry as well. Have any of you ever had one of your bosses take credit for something that you did? Raise your hand. A few, actually many. So I've had that happen to me twice. I was really disappointed. Actually mad first, then disappointed. And the bottom line is, as a leader, you'll get plenty of credit if somebody that works for you achieves good results. Never, 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 never take credit for something that you didn't do. And the power of letting somebody who works for you get the credit is just huge in terms of how people will work tirelessly to get results that you're all trying to achieve. Accountability. If never lower the bar. Whatever the bar needs to be in terms of achieving the results, don't lower the bar. Sometimes people will grumble and we can't do this and on about that. The bar needs to be here. Figure out how to empower the team, how to get the team to be able to achieve the results that you're looking for. Every once in a while, that's going to piss somebody off. Crucial conversations. We in pediatrics are nice people, and tend to shy away from crucial conversations or difficult conversations, but sometimes you need to have those, especially with the curmudgeon every now and again. It's not about you, it's about us. All right, so then you have to have a method of how do we get there? So I want to just point out that we have discovered at Nationwide Children's something revolutionary. It is coming out in New England Journal next month. We've demonstrated that this methodology works every single time to drive change and get individuals to perform better and differently.
When we asked Reebok to send us Terry Tate, some people thought we were crazy. But I'm a firm believer in paradigm breaking, outside the box thinking.
Hey, buddy.
Break was over 15 minutes ago, Max!
And since Terry's been with us, our productivity has gone up 46%. We're getting more from our employees than ever before.
You know you need a coach!
Works every time.
TPS reports, Richard, that ain't new, baby! Hey, Janice!
But what's really impressed me is how Terry's become part of the Felcher family. He fits right in here.
That's a long distance call, Doug!
Here's my favorite one.
To be honest, I wish Reebok sent us 10 Terry Tates.
Well, when it's game time, it's pay time, baby!
So there's a balance between that degree of punitive culture and the laissez-faire where anything goes. You know, I can break the rules. Nobody says anything. Nobody holds me accountable. I think there is a sweet spot between that, which of course is the ultimate in punitive culture, and holding people accountable. And if you don't hold people accountable, then the person next to them says, well, why should I follow the policy? Joe over there is not following it. Why do I need to follow it? It's part of leadership in terms of holding people accountable. Probably not to that degree unless you have people with really strong spines and extremities. So methods to get there. We have a specific method we use at Nationwide Children's, but I think any of these methods, whether it be the model for improvement, Six Sigma, and lean thinking, all of them can get you to good results. We just had a speaker at our place from Stanford, and they use lean. Lean's a perfectly good result. Seattle Children's uses lean. We use the IHI model for improvement. I do think, however, that using one standard approach to driving change and quality improvement methodology is good in that it reduces confusion around some of the terminology. We would never talk about a Gemba walk at Nationwide Children's, but it's really just leadership rounds. So it's really just confuses people, especially those that don't do quality improvement all the time. I think you need to train people. You're going through your solutions for patient safety, your safety training now, and I know talking to Abe, but there's more to it than just the safety training and the error prevention training. There's the science of quality improvement, how to understand data, how to use control charts to understand your data. We've had a course at our place now. We do it twice a year. Brian took the course, and it's an experiential course. You have to do a project. We've trained about 250 people. We've had some people from outside hospitals as well. But it's a 3-month course, about 40 contact hours. And at the end, hopefully you understand the science of improvement and how to use your data, control charts, run charts, Pareto charts, those kinds of things to look at what's happening, why it's happening, and how you figure out how to drive change. Just one slide, which we're going to publish in Academic Medicine later this year. Before and after, the blue bars being before in terms of people's self-reporting, how they think they've done on a Likert scale when their QI knowledge teams managing data and sustain and spread, you can see a big difference. And even 6 months after, we survey the same people and find that they still have an even higher score than the black bar that you see there. So that it actually gets at least some understanding from the students in terms of how they understand the science of quality improvement. We've had 47 projects of our 124 qualify for maintenance certification, so it's another way to have your physicians get maintenance certification. All right, so we've talked about how leaders lead, we've talked about teams, we've talked about a methodology to get there. The model we use is the model for improvement, the IHI model for improvement. What are you trying to achieve, the aim? What data do you have and how do you use that data? And what are the key drivers and interventions to get you to the aim? Nobody presents projects or talks about projects and quality improvement without a name and key driver diagram. It's just how we do business. It didn't start that way, but now it is an organized approach, much more linear, to sort of get you from point A to point B in a much more easy fashion. And then small tests of change to sort of try little things. You don't have to have a big project rollout. You can do it on one unit with one person, one clinician, and test it, and then see if that works, and then spread it further. This is just a sample of an aim and key driver diagram, but it's very specific from the standpoint, we will reduce asthma ED visits and inpatient hospitalization rates in a certain population by 3% by the end of 2013. I know what we're supposed to achieve. We either get it or we don't. If we don't get it, we figure out how come and how do we change our key drivers and our interventions to achieve those results. Culture. So I could spend an hour or more on just this slide, but I wanted you to just focus on a few things. The board. If your leadership, even above Abe and Joe, if they're not on board, no pun intended, with this work, it's much harder to get the buy-in from everybody, to get the resources and those sorts of things. So it's very, very important that your leadership, the board governance group, has both interest in, support of, and oversight for this quality improvement work. You're right in the middle of the high reliability training, error prevention training. Your leaders need to be out and about, walking around, seeing what's going on, asking questions. I know that you now have a much more in-depth root cause process than you used to. So do we. We used to have what I thought were pretty good root causes. I think we barely scratched the surface. I think now with our three meetings, we actually get much deeper into the root causes and external and internal transparency. So in our organization, we're a 10,000 people organization. There are 50,000 personnel training hours to get through all of this error prevention training. We increased our QI infrastructure, as you can see there, from 6 to 39 over 6 or 7 years. You don't do that in a week. You don't do that in a year, but incrementally, you need people to be focused on this. And I don't think you can do quality improvement cheaply, but I think that the ROI in terms of prevention of harm, one ventilator-associated pneumonia is $50,000, one bloodstream infection is between $25,000 and $50,000. You prevent a bunch of those, and all of a sudden you've saved the $3 million that we spend on this in terms of your ROI. But this isn't about an ROI. This is about what's the right thing to do for kids. If you're hurting kids, they're not going to get cured. So they're really, am I going to build a parking lot, or am I going to focus on quality improvement to get the results we're looking for? I think quality improvement trumps the parking lot most of the time. Not going to spend too much time on this other than to focus on the two in red. What we do now is we find a problem, we focus on what went wrong, put in place systems to try to prevent that, or individuals to try to prevent that from happening again. I call it preoccupation with failure. Wyke and Sutcliffe have written several books on this topic. It is the way Safety 1 is being conducted right now. In a few minutes, I'm going to talk to you about Safety 2, which might be the next step to help us get towards zero. And then commitment to resilience, which is we're still going to have harm. And you have to have a mindset and a plan to sort of what do we do when harm happens. We don't throw our hands up and quit. You have to have a plan to figure out how do we respond to harm when it happens. Do you all measure your safety and teamwork climate here?
We're about to.
Yeah. It's really, really important to give you a sense of not only what is the whole organization doing from a safety and teamwork perspective, but what are microsystems doing. We have, as you can see here, our safety and teamwork climate has improved consistently over the past 6 or 7 years since before we started this work until last year. But there are microsystems. There are some units that don't look at all like this. There are some units where the teamwork climate is actually poor. There are some units where the safety climate is actually poor. So in aggregate, it looks fine, but individual units maybe not so. And so we can target some of our efforts on those units where people aren't working together, where there isn't mutual respect, where there aren't nurses who are willing to speak up to the chief of XYZ service and say, have we ever considered doing it this way? And then the chief of that service instead says, that's a good idea, let's think about it, versus, how dare you talk to me that way? This is my plan, we're going with my plan. If you don't have that mutual respect between disciplines, you're not going to get the results you're looking for. That doesn't mean attending physicians aren't ultimately responsible for everything that goes on their service, but it's a team sport, as I said earlier, and attending physicians actually are stronger if you listen to other people who are maybe closer to the front line and closer to what's going on, because often they'll have ideas that you hadn't thought of. Not always, but you can certainly thank them for that suggestion. And just to show a little bit of data that supports that, the safety and teamwork climate is this blue line, and it's gone up since we've been working. This is our PICU. And this is our harm numbers in the PICU. Have published this as well. So there's a statistical association with safety and teamwork climate improvement between staff and harm reduction in the PICU. And Brian is working on a paper on this in the cardiac ICU as well. I know Brian's here, but I'm still bugging him about this paper. I think it's a good paper, and he's going to be first author on that. And we published this in the Journal of Patient Safety earlier this year, this association between safety and teamwork climate and harm reduction. You have to have both. One alone or one or the other is not sufficient. You have to have both. Celebrate success. If you have good things to say, make sure your staff knows it. Don't keep it secret. All the charts that have nice green lines on them like this, transparent, make people about them, celebrate them, thank them for their work. Thank you. This is not my work. This is not Abe's work. This is your work. You achieved this. Congratulations. Emails, even public celebratory kinds of things are important. You have to be a little bit careful if you make it too public. The next day, a disaster happens, and we wish we hadn't gotten too public, but that's sort of Murphy's Law, maybe. You know, we've been lucky enough to win a few awards, the CHA Pediatric Quality Award and the American Hospital Association Award for Quality and Safety. We publish a lot. Those of you that have a need to publish from your promotion standpoint, you need to get this work out there. You have a bunch of things on your internet that suggest that they could be published. There's this new journal called Pediatric Quality and Safety, which you mentioned. Send it to us if you can't get it published someplace else. We will give it a good peer review and see if it's worthy to publish. We have the fellowship, as you mentioned before. So if you have trainees who want to spend 2 years focused on pediatric quality and safety and leadership, come our way. We'll certainly look at whether you could come there. And you'll get a master's degree. And I do think in terms of quality and safety leadership, ultimately, a master's degree needs to be in your portfolio if you want to be the next Abe 10 years from now. Deming is my hero. So let's a little bit of data. This is our serious safety event chart. We've had the lowest rate we've ever had. This is 145 kids who weren't seriously harmed or killed. That would have been killed if the rate that we had back in 2009 had continued, which is the red line. So we're pretty proud of that. It shows we're not at zero, but again, dramatic improvement. And I think I haven't seen your chart like this, but again, I think this can happen. It's happened all across the state of Ohio and happened in many of the hospitals in the Solutions for Patient Safety work. This is our serious harm. So this is the number that was supposed to go to zero by the end of 2013. We didn't get there. We got there 60% of the way, but we didn't get there. So we are still working at it. As far as I know, nobody has achieved zero yet, but it doesn't mean that it's the wrong goal. It's still the right goal. Every kid that gets harmed is unacceptable in our organization and in your organizations. So it's still the right goal. And we will be on this journey forever. You'll be on this journey forever. Even if we get to zero, it'll still be there because you probably won't be able to sustain it. This is medication errors. You can see a dramatic reduction there. We have 200,000 meds dispensed per month, 5 meds per minute. And in the second quarter, we had 5 medication errors. All of them were the most minor. And in June of this year, we had 0 for the first time ever. 0 medication errors for the first time ever. So again, you can get close and you can have dramatic improvement. And we published this in the Journal of Pediatrics as well. And sort of the big dot of harm reduction is mortality. So the blue bars are our hospital mortality from 2000 to 2008, sort of before we started our safety work. And the salmon bars, or pink bars, whatever color you want to call that, is our mortality rate since our safety work began. And the red line is a severity adjusted mortality. So what the expected mortality would be based on APR DRGs from FIS data. So that's a 23% decrease in mortality since we started this work, 41% lower than expected. And here's the big number. Almost 300 kids didn't die that would have died. So I'm not saying it's only our safety work. We embellished our electronic medical record. We did a lot of things. But there has been significant improvement in our whole hospital mortality rate, all comers. So again, important outcome data that we put in front of our staff all the time to say, let's keep at it. We're not where we want to be yet, but we've made strong strides. Published this in JPEDS as well. So shifting, that's a very, very high view of this quality and safety work. But we're thinking about what's next. And I just want to throw this out to you a little bit. There's two domains that I think we need to focus on. Safety 2 and diagnostic errors. I talked to you about safety 1 before. So is this focus on safety 2 going to get us to 0? We're close, but we're not there. So is focusing on safety 2 going to get us to 0? So what is that? So safety 1 is we have a preoccupation with failure, either near misses, and if you focus on near misses, then you try to prevent the big misses, or when there is a real miss, a real harm event, you do root cause, you figure out what happened, put in place interventions, and you try to solve the problem. Sort of preoccupation with failure, we talked about that before. It hasn't gotten anybody in this country to 0. So is there other things we should be thinking about? So I talked to you about safety 2. There are only 5 papers in the medical literature on safety 2. All of them say it's a good idea. None of them have figured out how to operationalize it. We're in the process of trying to figure that out. But it's basically maximizing the number of normal events. Preoccupation with success. For example, our medication error rate is pretty low. What is happening on some units where they have almost no medication errors? How do we study that? So we're in the process of doing surveys with those nurses and other providers there and saying, how is it that you're getting this? And we have a structured survey which we're evaluating now. And then we're going to try to figure out what themes are there from that and then try to implement that. So it's more preoccupation with what are people doing. Sometimes a workaround is okay. Sometimes the policy, working around the policy is okay. And when is that okay? And how do you figure that out? And then how do you operationalize that in the organization? I can tell you there are other places that are working on this. I don't know exactly how it's going to play out, but I do think it's the next step to getting us to 0 harm. It doesn't replace safety 1, though. You got to do the blocking and tackling. You got to focus on what went wrong, why did it go wrong, do root cause analysis, and implement interventions to get the progression so that you don't have it happen again. Diagnostic errors. So you guys have diagnostic errors here? Raise your hand if you think you have diagnostic errors here. Okay, everybody in the room better raise your hand. We all make mistakes. If you haven't made a diagnostic error in your career, I think you need to look in the mirror, because I've made plenty. And it's what do you learn from that, and what do we do from a system? So let me tell you Edward's story. He's a 14-year-old boy, sustained multiple injuries from a bike accident. You can see them there. He was a level 1 trauma, taken to the operating room to repair all of his injuries. He had significant fluid administration in the operating room. He was in the ICU for 3 days. We gave him appropriate fluid, but a little bit hypotonic. He also took a large amount of fluid by mouth, free water. And on day 3, he began vomiting. You can see vomiting, headache, nausea. And so the team focused on abdominal injuries. What's going on? He had an operation. There must be something wrong with his abdomen. That's why he's puking. So with all the concern focused on his abdomen, nobody paid attention until day 4 of a sodium of 120. Boy, did we miss the boat. Boy, did we miss the boat. Embarrassingly missed the boat. I had water intoxication. We did fix it. He didn't have any long-term consequences of this. But we did not do a good differential diagnosis of headache and vomiting. So we've looked at this, and over the past few years, 21 of our root cause analyses have listed diagnostic error as a factor, not necessarily the factor, but a factor. And we think that's just the tip of the iceberg in terms of our important events. And one of the things that I see is this tunnel vision. Child comes in with wheezing and asthma, well, that's it. And we don't get chest x-rays all the time anymore. You probably don't either. Well, 2 or 3 times a year, that's congestive heart failure causing wheezing. And we miss it often. And it's unacceptable because it's the 4th thing on my list of wheezing that you can't forget besides pneumonia, foreign body, and congestive heart failure and asthma. But what happens is the kid comes in from another hospital, he's wheezing, he's got asthma, it must be asthma. We get this confirmation bias and people quit thinking about actually the other 20 things that cause wheezing. But there's only 4 you need to think about in the emergency room. So for those of you in the back, we are not good I don't think, at teaching the art of differential diagnosis to our trainees. So when you're out there on the wards, you need to be asking about what's the differential here. And I often hear, well, there's not enough time to go through the whole differential. Well, you don't have to do the whole differential on every patient. But what are the 2 or 3 things for this presenting problem that if I miss them, the child dies? If I miss it, the child dies. Asthma, there's 20 things. You don't have to talk about alpha-1 antitrypsin deficiency every day in the differential of wheezing. But you do need to talk about, is it a foreign body? Is it pneumonia? Everybody thinks of the pneumonia. And is it congestive heart failure? Do we need to get a chest X-ray to confirm it's not congestive heart failure? So I think we as faculty, all faculty in this room, we need to focus on the art of differential diagnosis better with our residents, our fellows, and our medical students. It's a national thing. 1 in 20 adult ambulatory encounters involve diagnostic error. The Institute of Medicine has a whole book. It's about this thick. I have it in my office. It's really great on telling us what the problem is. No interventions. They don't tell us how to fix it. So we have a task force in our place trying to figure out how to address it. But at least they're very good at articulating what the issue is. And it even made the New York Times, Diagnostic Errors. So eventually, some regulatory group is going to say we have to work on this, but I offer to you, start working on it now, because I think it's the tip of the iceberg of some of the harm that happens in your organization. I know it's the tip of the iceberg in what happens in our organization. Diagnostic errors, failure to accurately diagnose and failure to communicate. So first focus on the life-threatening possibilities, but keep the list front of mind. We're beginning to task the differential diagnosis with the senior resident on that service, and that they keep that list and they talk to us about it on a regular basis. It's a good learning for the resident team, and it keeps the attendings who are often trying to manage rounds. You could start rounds at 8 o'clock and finish at 2 o'clock if you weren't efficient. So I understand the time that it takes to do this. But if you want to look at the differential diagnosis of nausea and vomiting, 88 diagnoses. So I'm not suggesting you go through all 88 every time you have a kid with nausea and vomiting, but you probably, every time you see a kid with vomiting and no diarrhea, anybody in the back, on the back right, want to tell me what they should at least entertain for a second? Vomiting, no diarrhea, no fever. Very rare. Every once in a while, it's a brain tumor. And I mean that. And we have that happen periodically. Every once in a while, vomiting is the first manifestation of increased intracranial pressure, and it's a brain tumor. Now, I did general pediatrics for 10 years before I did critical care, and I would always, it would run across my mind for 2 seconds, and then there'd be a dozen other reasons why it wasn't a brain tumor. But I always thought about it. So you need to think about what are the things, 2 or 3 things, with every symptom that the kid dies if you miss it. Kid dies if you miss it. I use that word die on purpose because we have those in our place, and I suggest maybe you do too. Driving change is what it's all about. If we don't continue to focus on change and try to get better at what we do, as Deming said, survival is not mandatory. So articulated sell a vision, create and manage teams, have a method, celebrate success. And I leave you with this. If you're not paying attention to it, your team may not be paying attention to it. So attention is the currency of leadership. And you don't have to be micromanaging. You just, every once in a while, hey, how's that project going? What's the progress going on that? It gives your team awareness that you're interested, that you care about it, and you're paying attention. Attention is the currency of leadership. So leaders navigate the forks in the road. They make change just how we do business. And now I'll open the floor to short speeches disguised as questions. That's it. Thanks. I think people have microphones. Are you bringing microphones around? Mark?
Yeah, thanks, Rich, for that great talk, and congratulations on all this outstanding work. I wanted to ask you if you'd like to comment on your perspective on the Affordable Care Act, which I guess officially is called the Patient Safety and Affordable Care Act. What impact do you think that that's had on pediatrics, and how do you think we're doing as pediatricians compared to our colleagues in internal medicine and other disciplines with patient safety issues?
Yeah, that's a great question, and probably about a 45-minute answer, but a couple things. I would just make a couple comments. First of all, I think pediatric world to take the last part of your question, the pediatric world and its focus on safety and outcomes, I hope there aren't too many adult providers in the room here, I think is doing better. And the solutions for patient safety is the data for that. We have 120 hospitals focused on patient safety, and we're one of the most effective HINs, hospital information networks, that CMS has sponsored. So I think the data really suggests that we're out front, and often the adult folks are asking us how we achieve that. Now, the Affordable Care Act, we have a what's called Partners for Kids, which is our ACO. We're responsible for 350,000 lives, meaning we get a fixed amount of money from the state, and we have to manage all of those lives with that fixed amount of money. So we live this every single day in terms of getting better outcomes. So the ROI on that is if you have a fixed amount of money and you get better outcomes and you do it more efficiently without creating increased harm, that's a win for us. The other 50% of our book of business is private pay or insurance pay. So the increased length of stay, we make money on that. That's not the right thing, but we make money on that. For the other half, reducing length of stay, we come out ahead, and we're not a for-profit organization, so we spend that money and put it back into the organization. So that's an intro to say, don't know if this will happen in my lifetime before I retire, but I think that the driver for how we should be funding our health care is better outcomes. And I think it's coming that way with with Accountable Care Organization, other kinds of things. But as long as we get paid for mistakes, as long as we get paid for increased length of stay, as long as we get paid for harm that results in increased length of stay, where's the driver to make that happen? So I'm a firm believer that is the way we should go. I am not a firm believer that our country politically will ever go in that direction. There's some progress there. The adult organizations don't get paid for bloodstream infections. They don't get paid for pressure ulcers. I think that's coming to pediatrics. It's a drop in the bucket. Some of the adult organizations don't get paid for readmissions. Some preventable readmissions. That's probably coming to our area as well. So I think the only way that we are going to really improve, besides thinking about it like we do in pediatrics, is to have our wallet a little bit part of the driver to trying to reduce harm and get better outcomes. So I don't know if that answered your question, Mark, but that's how I look at it.
Thanks. Great talk. So as you've reduced rates, have you had difficulty sustaining the reductions? Have you had just this sort of natural acceptance, we're doing okay, and sliding back? And how are you approaching those?
Yeah, let me just get to. So for a while, we were getting discouraged by this. We'd had a big reduction, and then nothing happened. And we were saying, well, what are we doing wrong? We actually rolled out Zero Hero 2.0, which was a sort of reinvigoration because we've been at this for 7 or 8 years, and then we started to come back down again. I think in terms of if you get to a plateau, and it's a plateau like that, I think you celebrate that plateau, but you don't rest on that plateau. You say, what else can we do to take it from wherever we are to the next level down? I showed you the medication error chart, which is pretty down, but it's still not zero. So there's this mix. If I'm always coming and saying, we got to do better, we're not at zero. People get tired of that. And I understand the reality of zero. I understand the difficulty of even getting close to that. So you sort of celebrate the success you've had and say, well, what can we do to continue this success? And I think it's a nuanced message, but at the same time, if you're always saying we're not at zero, therefore you're not working hard enough, you're not doing it good enough, don't have the right interventions, people will start to tune you out. So I try to come with both sides of that coin. That's a successful chart, but it's not zero. So how do we? Yes, sir. So he's saying the cost of getting from where we are there all the way to zero is probably huge. So first of all the low-hanging fruit, all the easy stuff is done. That's how you get to a chart that looks like this. I'm sure you have charts that look like this as well. So I have 2 comments. One, if your kid or my grandkid is here, that's 100%. My kid dies, and I'm not going to, that's just not acceptable to me. But the amount of incremental effort, I think, to go from here to here, I don't know that it's a huge effort. I think if you have a strong infrastructure in place, you continue to capitalize on that infrastructure. And, you think about new ways to do things without necessarily investing in new people or new infrastructure, but be thoughtful. That's where Safety 2 comes in. We're not going to hire new people to do Safety 2. We're going to think about how do we incorporate and operationalize the concept of focusing on success as opposed to preoccupation with failure. So I think once you get to a sustainable low number, I think the incremental cost, this is my opinion, the incremental cost may not be as much as we think. It's more thinking outside the box, thinking about how do we do things differently. Diagnostic error, we're just tipping the iceberg, and Safety 2. I am convinced if we do those well, and I don't really know exactly how we're going to do them. We have 2 task forces working on it. I'll come back in a year and tell you what we've figured out, if anything, but the bottom line is I think that will really help here, because a lot of these serious harm events, like the 120 sodium, we just plain missed the boat. Now, nobody died there, but we've had others where we really missed the boat and kids die. And that's not unique to Nationwide Children's Hospital. I'm just fairly transparent about it. It happens in every big organization in the country. And in fact, if you don't know it, as I said earlier, it's probably going to happen if it hasn't happened. Does that answer your question? Yep. Yes, ma'am. I'll repeat it if you...
Earlier you were talking about team building and the importance of getting rid of toxic people, but also the importance of independent thinkers. And when they're naysayers, how do you differentiate between the two? Because one is toxic and one you really work with.
We have 10,000 people, and I can only think of 3 or 4 that are toxic. I suspect the same here. That doesn't mean they're not difficult. But toxic and difficult are a little bit different. And the naysayer, the person who says, we can't do that, my approach is, I really need your help. This is something that's really, really important. Look at this chart. We're still killing kids here. Will you work with me and the team on this? And if in 3 months we haven't done anything, you can raise your hand and say, Rich, you don't know what you're talking about, I quit. I have never had anybody say no to that, because all we want to do is try to improve. So you can, but I don't yell, I don't scream, I kind of get a little closer. I don't want to get too close to you, but just say to people, I need your help. I've not had anybody say no when I say, I need your help. And I think any leader in this room, I need your help. Please help me. We need to do this together. You have so much insight, so much expertise. You need to be part of this team, and I want you to help us figure this out. But they need to give them an out. Okay, in 3 months or 6 months or a year, you can say, you weren't right. What's your first name? What's your first name? Kim. Kim, see, I told you it wasn't going to work. But I bet you almost always it is going to work. When we first started talking about zero here, I had our chief of neurosurgery stand up and say, we'll never get to 0. And I'm not on board. I said, okay, the rest of us are going to go forward with this. I just ask that you stay out of the way and not get in the way, and let's see what happens. In a couple of years, he was a cheerleader for this and really on board with it as we started to see results. And then if you don't deliver results, well, then you got a problem anyway. If you're not doing whatever the implementing strategies are probably not working. I can tell you that our quality improvement infrastructure wouldn't have gone from 7 to 35 if we weren't getting results. My CFO and my CEO would be saying to me, sorry, Charlie, you're not getting results. We need to rethink about how much investment we're going to do with this. So you do have to deliver results. But I've not had anybody not say, I'll work with you. Even the most difficult people. And I know who they are. And you know who your difficult people are as well. Thank you. Good question, Kim. Thank you. Anything else?
One more question. Thank you, Rich, for being here and doing this. We really appreciate it.
Thank you for your time. Really enjoyed it. Thank you.